you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
Kim is at her daughter goes to a Catholic girls' high school that has a soccer team, and her husband is the coach for that team, but her daughter's a senior, and tonight is their baccalaureate mass. It's a special mass just for the people that are graduating. So that's why she's not here. And rather than go yet another week without a podcast, I figured I'd show up. And that means it's just you and me. I'll tell stories because we did a 5-day core seminar between last Wednesday and Sunday. And it was really cool. We had 12 people, naturopaths, a couple of civilians, one ultrasound. She does ultrasounds for the last 20 years. And there's a chiropractor, an FSM chiropractor in her town that is retiring, and his patients are freaking out because there's nobody around in Utah that does FSM. So she's going to dive in and see his FSM patients in an office supervised by a nurse practitioner. Anyway, so she was there. David Young was there. He is a naturopath who took the course. Hi, Annie. Who took the course in first course, January of 97. Between course and advanced, he has had, maybe it's all course, were 17 core seminar plaques. Then he showed me a video of all the advanced that he's done. And he did, I think, one master class maybe, but that's David Young. He's the one that goes through all the slides and creates the index. So he was there. He's a naturopath. And the magic thing that happened was that one of the non-practitioners who was in the class, 15 years ago, he had a herniated disc at L5-S1 with an extrusion onto the S1 nerve root. And by the time they got him, because he had no pain, it just went right onto the nerve root. He had no nerve pain. And he went across to his neighbor, who was an orthopedic surgeon, and his lower leg muscles were already not firing and his foot was numb. And the guy said, "You get to go to the emergency room right now." So he went and they did the surgery, got the fragment off the nerve root, but his calf muscle was completely flaccid with fasciculations. That's when the muscle just flickers. And that's what happens when it's denervated, like the nerve is disconnected and the muscle randomly fires. And bottom of his foot was numb. So we started on Wednesday, Thursday, Friday night. I treated just 40 and 396. And the calf muscle came back and he went, "No way." So it produced bulk. It would fire. If I did, what I usually do is increase secretions in the nerve. Annie, I'll get to the question in a second. Increase secretions in the nerve. That actually made the muscle go flaccid again. So the nerve was like not ready to be forced into conducting anything, much less acetylcholine. And so we ran 40 and 396 and 49 and 396 and all of that. And then the next night, we ran 40 and 396 and the muscle was still bulked up. That was good. Then we could run 81 and 396. Scar tissue took the scar tissue out between the nerve and the fascia, nerve in the bottom of his foot. And so there's bulk there, but does it work? So we switched to increased secretions in the cerebellum and had him point his toe and use that muscle. So that was cool. And it's, each time, where you set the 2 towels. Thank you, Louise. For the S1 nerve root, what is the basic rule about treating nerves? I'll let you answer it. Those of you that can answer it in your head, yay. It went from his low back, where the S1 nerve starts, and then down, I wrapped around the back of his leg, around the bottom of his foot. And after the first day, there was this gap, this ditch between, I guess, the tib anterior and the gastroc and soleus. So like the proneus, longus, and brevis were just like missing. They were just not there. And when I had him evert his foot and tried to apply pressure, his TFL contracted. So that goes from up around his hip bone to just below the knee. So his TFL was trying to do the job of the peroneus, longus, and brevis, which are everters of the foot. So that's when you tip your ankle outward and press to get it to contract. So I had him keep his hand on the TFL to keep it quiet. And then I kept running increased secretions in the cerebellum and had him keep moving. I kept moving his foot into eversion and inversion. Make a long story short, it took us about an hour, and the muscle was strong. He could point his toe, so his gastroc was working. The bottom of his foot was no longer numb, and his foot could evert. Being a chiropractor, I used an activator, which is an adjusting instrument, and adjusted his talus, which at this point, he still runs 1 to 3 miles a day for the last 15 years. And all of his shoes, he supinates because he can't pronate, right? The muscles that do pronation don't work because they're S1 and L5. Got them to work with him laying on the table, then put a wrap around his neck. And this is for you, Louise, and everybody else that wonders, where do you put the leads? Put wrap around his neck, wrap around his right ankle, and had him do in place without moving, weight shifting side to side, stand on your toes, stand on your heels, step back, step forward, all of the components of movement that you would do if you were walking. And then we did 81 and 92, increased secretions in the sensory cortex, had to do the same things, and the quality of the movement changed. Then carried a precision care and had him walk barefoot. He said, I can feel the carpet on my feet. Had him walk barefoot from the seminar room out to the front and back to the seminar room and then out. And most of the time we were on the 81 and 84, increased secretions in the cerebellum, and then increased secretions in the sensory motor cortex. And pretty soon he's walking completely normally, except his hands are like, and arms are really stiff. And I said, dude, relax your arms. Salsa dancing in the kitchen. It'll work. And then that's when you know the brain is connected to your feet and it's not worried about balance and it's not worried about where to put its feet. And his only rule was, number one, you're going to be sore tomorrow and you are not allowed to run until you go to a running store, have them videotape you, because I don't know whether you need pronation control shoes or I don't know what to do with a foot that's been supinating for 15 years. I just couldn't do that. So he was good for that. And that was the miracle for the week. We had 2 Ehlers Danlos patients who didn't know they were Ehlers Danlos. One of them was a student, and she had a chiropractor look at her, didn't measure the Baden points, just looked at her and said, "Oh, you're not hypermobile." History of sprained ankles, working on her neck made her worse. In between her shoulder blades, she had a rib that was always out. She had 9 out of 9 Baden points. Her elbows retroflexed by 5 degrees, her knees retroflexed by, or extended by 5 degrees. So that was pretty cool. So we treated her for 40 and 10, treated her for the vagus, treated her with 124 and 77, basically the whole Ehlers Danlos patient. And then the next day she came in and said, "I'm feeling anxious." And I validated that by saying, "Of course you are. Lift your little finger up." And it stopped at 70. And straighten your elbow. And it stopped at 0. And I'm not sure what's causing your anxiety, but let's see if we can stop it. So I tried 40 and 89. That didn't do anything. And they said, "We think it's emotional." And let's just try 40 and 562. Quiet the activity of the sympathetics. And she was all ready to have towels on her neck and towels on her feet. And I said, "No, just hold these in their hands." And she did 40 and 562. And in about 5 minutes, she's giggling and her anxiety's gone. Then they ran various emotions on her anyway. At this point, the practicums were all free-for-alls. We had 1, 2, 3, 4. We had 4 tables. We had 4 out of 4 had ureter and psoas, causing ureter adhesions on the psoas, so 13 and 60, causing tight psoas muscles. That was really fun, which is followed up by scarring in the kidney, where you rock that, and then sclerosis in the adipose, where you rock that. We had 1 ovarian cyst, old ovarian cyst, that was scarred, and the ovary was scarred to the tube, the cecum, and rolled over and stuck to the bladder. So we did scarring in the ovary, scarring in the tube, scarring in the bladder, scarring in the cecum. And what's really fun is that you can demonstrate to the patient about how it is that I knew that the cecum was glued to the ovary. Number one, you could feel the scar tissue where the ovary should be. So on the left side, all soft and smushy, pain-free, non-tender, everything's fine. You could feel the sigmoid colon right down in the curve of the pelvis where it should be. On the right side, I said, "Now feel this." And she said, "Oh, that's hard." I said, "Yeah, that's your ovary. Now feel right next to your pelvic bone. There's nothing there." Okay, she's a naturopathic student, so that was good. She knows her anatomy. So it should be there, and it should feel like a sausage casing filled with really liquidy sort of oatmeal. And it was maybe 2, 3 centimeters medial, glued to the ovary, glued to the tube. So as we unstuck things, it went right back where it belonged. So that was really fun. Okay, those are my tales from the seminar. It was really fun. Let's see. Okay, so we took care of Louise's question. Let's take Annie's, and I'll get to everybody since it's just us. A question for later. It's later now, being 20 after 3 already. Charcot-Marie-Tooth. It's, wow. I have had one Charcot-Marie-Tooth patient, and I have to look it up because I forget. Right. It is hereditary disorder that damages the nerves in the arms and legs. Degenerative nerve disease appears in adolescence and early adulthood. Muscle weakness, decreased muscle size, decreased sensation, hammer toes, high arches. Main treatments are physical therapy, occupational therapies. Medications may reduce the pain. The patient that I saw, this high arch that this Google thing talks about, on her, because of the vascular part of and muscle weakness in the feet, ankles, and legs, the feet are highly arched, which can make the ankle unstable. The bones in her foot were degenerating, and that's the only case I've seen. So if Dr. Google here is right, and this is from Mayo Clinic, so we hope they're right, you would treat, it's hereditary. So you'd have to look up, Annie, look up, is it dominant or recessive? And see if you can find out what genes are involved. Are the genes that affect the nerves? It sounds like it says it's degenerative nerve disease that appears in adolescence or adulthood. That suggests to me that these kids are born with normal feet and legs, and over time, if it appears in adolescence or early adulthood, it means they're normal for a period, and then there is a trigger of some sort that triggers it's the epigenetic environment that changes the genes and makes the genetic condition, the genetic degenerative nerve problem, show up. So he was diagnosed when he was 12. That's apparently pretty normal. But what's the gene involved with? So if it's genetic, the gene having, let's say it's recessive, so you have a double recessive. So you've got the gene, or maybe there's 4 or 5 genes involved with it. That I don't know. But something turns that gene on when you hit adolescence. What is it? There's some epigenetic factor, and most genes have things that they do. So what's missing? What intermediate is missing? Is it B12? Is it B6? Is it glutathione? Is it CoQ10? Is it the mitochondria in the nerve eventually dies? I'm asking questions because I don't know. I would have to look it up if I saw a CMT patient come in. I'd have to look it up and find out what genes are involved. Most of the time, the medical profession doesn't worry about how exactly the gene works. That's a Jeff Bland functional medicine way of thinking about genes. They have certain requirements, intermediate steps, or that genetic change means that nerve with that gene needs more of X, Y, or Z, or X, Y, and Z. So you have to provide more substrate. If it's neurologic, muscle weakness, 81, 40 in the nerve, 81 in the nerve. Is it the nerve really, or is it the blood supply to the nerve? Because it's muscle weakness, so it suggests it's actually the nerve. So this is, when I say that the core is about teaching you how to think, this is how I think through things. And then I use the frequency response to tell me whether or not my thought processes are correct. Okay, if I treat the nerve and nothing happens, if I do 40 in the nerve and it gets better, then I'm on the right track. If that doesn't work, then what? Maybe I have to do 81 on the nerve. Maybe I have to do toxicity in the nerve. Maybe I have to do viruses in the nerve. What made the nerve, what made the genes in the nerve stop working? Does that make sense? I hope so. But that's the thing, is figure out what's wrong with it. Because the basic rule with FSM is what tissue is it? What's wrong with it? So you got to find out what's wrong with it. And then give yourself time to look it up, figure it out. 4 treatments, 5 treatments, 6 treatments. And it seems to affect, according to this thingy, it seems to affect the lower legs and feet. Oops, no, nerves in the arms and legs, muscle weakness. So maybe arms and legs, that's peripheral nerves. So maybe neck to feet, maybe neck to hands and low back to feet. I don't know. But when I encounter something I haven't treated before, this is the process. You look up the condition, try and see what the medical literature or whatever information you can gather, see what that says about it, and then start trying to fix it. That's as good as I can do. Sorry, Annie. Good luck.
She's got more stuff at the bottom, I think.
More stuff at the bottom.
Yeah, I think that's where she was responding.
I've not seen the patient yet. Son of a friend, multiple types of CMT, don't know which he is yet. Yes, it's progressive, deformed feet, yes. Researching at genetic aspects, epigenetics. Yeah, I've seen an N of 1, and by the time we figured out it was Charcot, she was diagnosed with Charcot because I was treating her like a diabetic neuropathy. By the time they figured out it was CMT, it was game over. But good, yes. Good decision. Good luck. Keep me posted. All right. We've got Louise took care of you, I think. Myasthenia gravis. No, actually. One of our practitioners had myasthenia gravis, and it's antibodies that attack the acetylcholine receptors, as far as I know, in the muscles. So it's not exactly nerves. It's probably, you have to treat the vagus because you have to get the autoimmune condition turned off. Treating 46, the sarcomere, 40 and 81 and 396, I have more luck with than 124, but you can try 124 because it's not really torn and broken. It's the nerve goes here, the muscle's here, the nerve is here and secretes acetylcholine that makes the muscle contract, right? The antibodies gather around that receptor and get in the way. So it's not actually anything wrong with the nerve. It's the receptor in the muscle. So you have to pound the vagus, find out what turned it off. With all the autoimmune patients, it damages the neuromuscular junction. A neuromuscular junction is that. So you have to, with all of the autoimmune patients, it's what happened just before, 1 to 3 months to 6 months before what happened. It's almost always some sort of trauma. So concussion in vagus and vagal tone and leaky gut, and treat the nerve, treat the muscle, treat the vagus, treat the immune system, tell the immune system to stop being silly and attacking your own body. That's rude. But the way you get the immune system back under control is to treat the vagus. Speaking of autoimmune diseases, the scleroderma, you are the first 28 people to hear this. The scleroderma paper has been accepted by the Journal of Rheumatology for publication. So that's huge. It's huge. Walter and I did this research maybe almost 8 years ago in Leeds. No, it was when was COVID? 2020? No, it was before that. It's 2019, 2018, 7, 8 years ago. We treated 8 scleroderma patients in a week. Then he treated another group after that. The statistics are huge for scleroderma. It's an autoimmune condition where the capillaries in your hands and even forearms go through an acute phase of inflammation, like they get really inflamed and painful as the immune system decides that your capillaries belong to somebody else. And after the inflammation comes scar tissue, and gradually over the next 3 to 5 years, they do this. And there's something called the Colchin, Colchin, hand score. And one of the tests is, can you pick up a coin from the table, right? And the increases in or improvements in Colchin hand scores were in the responsive patients, which were usually the ones that had it the shortest amount of time. Early and middle stage is always better, but the end of it, sometimes it's not possible to get it back. But anyway, the statistics were great. Then Walter went on for the next 2 or 3 years and treated local patients in the scleroderma support group and found out that it helps with the Raynaud's as the sympathetic receptors. That's our autoimmune case. Yay. Thank you, Debbie. Yeah, I'm really excited. I've been harassing poor Walter on and off for 3 or 4 years as he got his own health back. And then harassing gently paid off because he got it together. And between the two of us, we wrote the paper up. He mostly wrote it up. And the supervising rheumatologist that leads the rheumatology department at Leeds Hospital in Northern England put his name on the paper. So that's probably why it got published. I'm pretty excited. Okay. Encouraging. Thank you, Debbie. Encouraging is better than harassing. Reminding, gently, encouraging. Okay, Suzanne, client has Ehlers Danlos, female, 43 years old. Saw you at a conference, diagnosed her cervical disc bulge, 5'6", working on several foot issues, 40 and 10. Okay, whoa. If she has Ehlers Danlos, you don't do anything but treat the Ehlers Danlos. Okay, number one, in an EDS patient, if I diagnosed her, if you diagnosed her, if she's got hyperactive patellar reflexes and Ehlers Danlos, you treat 124 and 77, review the Ehlers Danlos webinar, and neck to feet, 124 and 77, neck to abdomen with a second machine, turn the vagus on. And if you're going to run 40 and 10, you have to run it alternating, but you get sensations in the jaw. I'm not sure what that means on one side. And on the other side, on that one side when it's positive, and the other side when it's alternating. Usually the sensations in the jaw, if you check sensation with the little pinwheel in the lower 2 branches and the forehead, the lower 2 branches connect the trigeminal nerve with the C4 and 2, 3, and 4. There's a loop for the trigeminal that comes down in the neck as far as C4. So if that 5'6" disc bulge goes up at all, enough to irritate the cord in the 4-5 area, You could be stimulating branches of the trigeminal nerve. Sensations like pain, sensations like what? Sensations. I'm not sure what that means. Haven't gotten to the neck yet. You run disc repair, you run concussion and vagus, you run 124 and 77. The other thing, no, don't start addressing the TMJ. That's like rearranging the deck chairs on the Titanic. The TMJ sensations in the jaw are not necessarily TMJ. If somebody has Ehlers Danlos, every connective tissue is going to be loose. So the pterygoids attach to that disc with a flat connective tissue attachment, and that's stretchy, and it gets partial thickness tears, and it's going to make the muscle really tight. Then when you open your jaw, it's going to pop because the pterygoid is tight and it won't let the disc go back in. So treat the disc. And this is at least a 2, if not 3 machine sort of thing. If you can begging and borrow is better than stealing. But it's 124 and 77. And in the C-spine, it's going to be 124 and 443 for the neck pain. If you're going to treat the TMJ, do 124 and 77 side to side on the face. That's the only thing you want to do to the TMJ. And then get the vagus turned on. There's that. Good luck. It's like, I don't know how to treat an Ehlers Danlos patient with less than 3 machines. It's like, you've got to treat the vagus, you've got to treat 124 and 77. And we did actually, the only way to get rid of the neck pain and muscle tone in this one patient was 124 and 443. The dura is made of connective tissue and the neck muscles will be really tight. The other thing is that this Ehlers Danlos patient in the core ended up, they were treating her from something else, or I was treating her for something else. I came up and I checked her pectineus and Dr. Gravis. They were just really tight. Then I checked her hamstrings and it was ow, and her pectineus and brevis were ow. And that meant that she was a 40 and 10 and an 81 and 10 and 124 and 77 and turn on the vagus and 40 and 10 alternating, along with 81 and 10, and in your case, 124 and 77 side to side across the face. I don't know how to do Ehlers Danlos with fewer than 3 machines. They can all be custom cares because you can program single frequency combinations into it. Okay, hope that helps. I wouldn't start dressing the TMJ without doing 124 and 77. Okay, Debbie, benign prostatic hypertrophy in a 70-year-old male, had a dentist when he was 12 that was utilizing his father's medical coverage. So he has 5 root canals. While the benign prostatic hypertrophy is pretty normal in a 70-year-old male, it's just they need to get a scan, CT scan. How do they check for prostate cancer? So you need to make sure that the prostate is just enlarged. Yeah, my experience with root canals is they're going to kill you. That's just, there is the thing to do when somebody has, Alf says it's an MRI for tumor. Thank you very much, Alf. A 3D cone beam. Anybody with that many root canals, especially if they were 12 when they got the first ones, they never don't fail. And so you have him search 3D cone beam, CONE dash BEAM 3/D cone beam near me, and you send him to, if you don't already know somebody that you trust, you send him to an oral surgeon that has a 3D cone beam and find out what his jaw looks like. It's not related to the benign prostatic hypertrophy, but it's going to be related to his immune system and a bunch of other stuff. That's how I ended up with open heart surgery and 2 hip replacements. All right, Louise, previous Zoom, I asked you about how to treat pudendal neuralgia, 40 in the nerve, pelvic floor. No, seriously, they do dry needling in the pelvic floor muscles? Jesus. Okay, I'm just gonna calm down now. Wow. Pudendal nerve entrapment between 2 pelvic floor muscles coming out of the sacrum is causing the inflammation. Very frustrating to patients as nerve block. Stopping the pain is the diagnosis. I understand. They got it backwards. The nerve gets inflamed at the L5S1 nerve root, or maybe even in the sacrum, or some other cause. And what's all good and comfortable? No, FSM can do 40 and 396 from S1 and the sacrum and then down to the crotch. That's a nerve block. And then treat the L5S1 disc. And the pelvic floor muscles get tight because the nerve is irritated. What nerves innervate the pelvic floor muscles? S2. So wow. All right. Penile nerve entrapment. What makes the pelvic floor muscles tight? I don't know. It just comes from space, right? S2, 3, and 4. Oh, anybody do an MRI of her sacrum to find out if she has tau cysts in the sacrum, which are pretty common? I would still treat the nerve. And yeah, 40 and 396 is like a nerve block. And nerve blocks, especially pudendal nerve blocks, especially L5S1 nerve blocks, it's S2, 3, and 4 nerve blocks, are neither comfortable nor entirely safe. How would you assess compression of the nerve? Common among long-distance cyclists. Wait, let's go back. She's a long-distance cyclist. So, yeah, poorly fitted bike, duh. No, it's the other way around, Louise. No. If you look at where the pudendal nerve runs along the ischiums, along the pelvic bones, if you're sitting on a poorly fitted seat and pedaling, you're creating you pin the pudendal nerve on the seat, and then you rock your pelvis. So you're creating nerve traction injuries, I don't know, after a mile or two. So get her a properly fitted bicycle seat. The pelvic floor is not compressing the nerve. Irritation in the nerve is causing spasticity in the muscle, which then it's like a triple crush, like neck, here, and here. People that do dry needling think it's the muscle. If you can go through the core seminar and still think it's the muscle, it's because they have needles that they can put into the pelvic floor, especially if they're really tight and neurologically sensitive, that would really hurt. But anyway, because they have needles that they can put into the muscle, to pepper and destroy portions of the muscle, they think it's the muscle. Louise, please tell me it's not the muscle, please. I'll feel much better if you say you get that. They think it's the muscle because that's all they can treat. They don't have a way of treating the nerve. You do. So, number one, get her a bicycle seat that's fitted properly. Number two, get it padded. Number three, treat 40 and 396. And you basically go from the L5S1 down to like the tailbone. So you pick up 2, 3, and 4. And then put a washcloth on her crotch, like the end of the pudendal nerve, and polarize the pudendal nerve. And if your scope of practice includes palpating the pelvic floor muscles, and if your scope of practice includes putting needles into it, I'm going to guess you're allowed to touch it. Put a glove on, put some lubricant on, reach up and feel it. When you run 40 and 396 or trauma in the nerve and 40 and 396, does the pelvic floor muscle, do they relax? If they do, then I'm probably right. But if a nerve block is going to fix it, that's what 40 and 396 is. It is a risk-free nerve block. Yay. Alf, I'm not sure what you're saying wonderful to, but I'm glad you think it's wonderful. Yay. Laura, researching how to detoxify from airborne toxins that have suddenly mass accumulated in our atmosphere that we breathe. Well, there's nothing sudden about it. It's been going on since about the industrial age in 1930 something, but that's another thing. Researchers are saying that aluminum levels are seriously high. 3 different researchers. Yeah, that's supposedly what chemtrails are about, is microaluminum, and I don't know what that is. Advanced frequencies list aluminum as 33 and 37, with 27 is part of the colon. But the thing is, if they're airborne, where are they going to go? They're going to go into the sinuses. Aluminum's heavy, so it's going to drop out in the pharynx, the larynx, the bronchi, and the lungs. And you'd have to look up what to chelate specifically with aluminum. Thank you, Louise. Because once you start releasing them, you have to think about binding them in the gut, magnesium and malic acid for aluminum. But here's the other thing. Does the patient have symptoms that you are attributing to airborne aluminum? Has anybody done urine or blood or any kind of testing? Okay. So yes, you have symptoms, and somebody's done testing to tell you that those symptoms are caused by elevated aluminum levels. They know that aluminum is elevated in early cognitive decline, and I think Alzheimer's, but they're not entirely sure why, because you have an entire population, aluminum cans, aluminum foil, aluminum little oven trays for stuff before they turned into paper. So we were exposed to aluminum seriously. I could remember eating TV dinners in the 50s that were on aluminum. And people use wrapped potatoes. I used to wrap my dad's baking potatoes in aluminum foil. So we have all sorts of exposure to aluminum. Not sure what your symptoms are. What? Antibiotics with negative cultures? I'm not sure what they think is infected, but that's strange because usually they don't want to put you on antibiotics for much of anything. So go ahead and use 33 and 37 on A, but whatever they think is infected, put that on channel B rather than 27, and find out what binders. Make sure, stop using aluminum cookware. I figured that out, I think, in the 60s. Does anybody still use, it's a good point, Annie. It's like having a conversation with you guys. This is so fun. We get to do a 4-day advance next year because of whoever asked me. It was sitting in the second row over in the left side of the room. I said, okay, I'm going to completely rewrite the advanced, and it's going to be 4 days. And so there we go. It's try aluminum, but look into it further. Don't just, I would go with whatever Alf said, magnesium and malic acid. And then somebody said David Musnick did a talk about toxicity is like his favorite thing at the Advancing Symposium. He did 3 hours. No, restaurants still use big pots of aluminum. That's obnoxious. If there's time remaining, could you please address detoxing from root canals? Working with a dentist, whoops, where'd you go? Who I want to take Dr. Chandler's course, and ties her with this conversation. There's no way to detox from root canals. You get a 3D cone beam and your jaw is either infected or it's not. And you get somebody that has the new version of the software, and there will be pieces of the cortical bone, cancellous bone in the jaw around the root canal that just doesn't look white on the CT scan. And so the solution is you have to get the root. There's no detoxing root canals, that you take them out. So the problem with root canals is the root is like this cone thing, right? It's made out of straws that go this way all around. And the straws, it's like trying to sterilize styrofoam. Straws go out into the bone. They remember when they do that file thing in the tooth, when they're taking the nerve out. So they take the nerve out so the tooth doesn't hurt. And then they're supposed to pack it with stuff that will be an antibiotic, or they're squirt antibiotic stuff down into the root. It kills the aerobic bacteria, but my understanding is it drives the anaerobic bacteria out into the jawbone. Anaerobes, they grow very slowly. So I had my first root canal when I was 19. The one that caused my stent was put in, no, the one actually caused my heart surgery, an infected gallbladder that was probably caused by the infected root canals. That was in 2004 when I got the stent. And then I had a root canal in January of 2007, and the stent collapsed and plugged up the left anterior descending artery in March, 3 months later. So infection is, in me anyway, is a cardiovascular risk. So I don't mess around with it. A chronic bone infection causes inflammation that activates the immune system and kind of makes it lose its mind, turns the vagus down, so your digestion doesn't do great, your immune system gets out of control, etc., etc. Yeah, there's a book for this dentist. Dr. Chalmers hasn't written her course yet, and that's, I guess, another place for me to start encouraging people, or if Mary Ellen, harassing is just not a thing you can do. So encouraging, reminding, asking her when would be a good time. That's a good thing. But there is a book called The Great Root Canal Cover-Up. I suggest you read it because it's unlikely your dentist is going to. And I think it was written in the 60s, maybe 70s. And they have taken root canal teeth out of, they've taken teeth with root canals in them out of patients who have, let's say, arthritis, and they take that tooth and they insert it under the skin in a bunny. And inside of, I don't know, 2 weeks, 4 weeks, some period of time, the bunny had arthritis in all of its little hind legs, which was not good for the bunny. So there we go. Yeah. Anytime you have a chance to go back over either the video or just the slides that you were given for the Advance and Symposium, I'm hoping to entice Dr. Musnick back for an afternoon lecture and maybe one of his famous 3-hour morning lectures. The first 2 days will be a repeat of what we've had before in the Advance. So those of you that have done the Advance before probably don't need to repeat those. There won't be a breakout session for the last 2 days because nobody's seen that. I haven't been through those slides, I think, since about 2005 or 6, maybe even 7. So we'll have, I hope, Dr. Musnick back in 2026. I'm going to be 80 in September of 26. That's just nuts. A 5-day core. Debbie, you can come to a 5-day core any old time, and you can get it on video. We had a really good copy of that, film of that this year at this year's Advanced. I was kind of on message. It was pretty fun. It's a little bit different every time I do it, or you hear something different. This is why David Young, he's a naturopath, has been to 17 of them since 1997 when he took it on green blackboard and chalk. And he even got, at the 10-year mark, I gave out something called the Whiteboard Award. I found George's around someplace. And is it over there on the shelf, the Whiteboard Award? There it is. It's right there behind those books. See it? No, to your right, that thing. Right there. This is what I gave out to people on the 10th anniversary. This is our old logo. And it says, on the 10th anniversary of frequency-specific microcurrent, in recognition of the vision and enthusiasm, dedication it took to hang in there with frequency-specific microcurrent in the early days. And this is back when we had the Advanced in February. This was February 24th of 2007. So this was George's. I don't think I kept mine. So here we go. Yeah, it's Louise. Thank you very much. May we all look as good as you do when we turn 80. I was looking at myself yesterday. Remember, I told you when I start looking like Winston Churchill, I run Skin Anti-Aging. I created a 209 minutes. What's that? 3 hours and 20-minute version where I put sticky pads on my forehead and chest, or forehead, and the second half of the night I put it on my face. And so red on the right, black on the left, green, yellow, or green, yellow. And I ran it 3 times last night. And it's a little bit better today, but it usually takes 2 or 3 days for it actually to show up. And that's the secret. And I love telling people I'm going to be 80 because I know I don't look like it. And that gives me a chance to tell them about FSM anti-aging. That's pretty fun. And Debbie says, yes, you learn something every time you rewatch it. And that's because I teach it a little bit different. Kevin is looking forward to the day when I don't change it. And I'm not sure that's going to come because we just took 60 slides, 70 slides out of the front of the core. That's just too much even in 5 days. And we're going to have people watch those 70 slides before they show up for the class. And then, so I say it a little bit different, tell a little bit different stories. Some of the jokes are always the same. But it's that you change more. You have a bigger matrix to put that same information in and so you're different. And Kevin says, it's time to go. It's 4:03. Okay, then. How did we talk for a whole hour? Thank you for asking such great questions. That was really fun.
We'll be back next week with Kim.
And I'll be back next week with Kim. Yay. That'll be fun. Find out how graduation was. Have a good week. Do good things. Change lives. Change the world. I love y'all. Talk to you later. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.